a quick review, the pharmacology of sedative hypnotic drugs. The sedative hypnotic drugs, we can classify them into the sedative agents, which they are reducing the anxiety and producing a calming effect, and the hypnotic agents, which will be produce drowsiness and then will be leading to encourage the onset and maintenance of a state of sleep. So we're starting with anxiety. So we know that is going to affect almost all the body function. So if we started with the brain, for an example, we see that the patient have an increased incidence of depression. He has a headache. He or she has a headache. Then also an inability to sleep. Beside that, he is have an excessive worrying about daily matters. He is having a fear of dying or losing control, fear and avoidance of social situations, irrational fears that interrupt daily functioning. The other part of the body also will be affected. So the patient will have a heartburn, stomach ache, and also will be having a rapid breathing beside a tachycardia, increase in heart rate, increase in blood pressure. All of that, it might be leading to an increased risk for heart attack. Beside that, the patient will be having a tension in his muscles, some kind like a spasm. Will have an increase in the blood glucose, and the immune system, it will be very weak. Also, he will have a low sex drive, so they will be having a fertility problems. For an example, in a male, he have erectile dysfunction. In a female, she will have a missed periods. So now let me remind you about the sleep stages and the sleep cycles. So we have the person, normally he will be awake, and then he will be going into the first stage of sleep. The first stage of sleep will be taking about like a few minutes. Usually the heart rate and the breathing will be slowing down, the muscles start to relax, and the brain start to produce alpha and theta waves. Then he will be moving into the second stage. The second stage, it's the duration of it about like 20-25 minutes. Again, we have a further decrease in the heart rate and the breathing. The body temperature also will drops, and the brain waves start to spike up and down, so we'll be producing a sleep spindles. Now, this stage 1 and stage 2, we call it a light sleep. Then the patient or the person will be moving into stage number 3 and 4. In stage number 3 and 4, here we have what we call it the delta sleep. It will be very difficult here to wake up the person. It will be very difficult. The heartbeat and the breathing also will be going farther to slow down. The body is really fully relaxed, and the delta brain waves are present. That's the reason we call it delta sleep. In that stages here 3 and 4, we have the tissue repair and growth, and the cell regeneration occurs. The immune system, it will be strengthened. And these stages 3 and 4, for that all of that reason, we call it a deep sleep. Then the person will be suddenly, and all of that stage 1, 2, 3, and 4, we call it a non-REM sleep, and we'll see why we call it in this non-REM sleep, because the stage number 5, it is the REM sleep in stage number 5, which we mean that the patient start to have a rapid eye movement. Usually will be happening about like 90 minutes after falling asleep. And this stage, it is a stage of dreaming. It will last about like 10 minutes in the first cycles, and then with every cycle it will be increasing until probably the final cycle it will be last about probably 60 minutes. In this stage here we have a rapid eye movement, the increasing in heart rate and the breathing, suddenly it will be happening, and even all the muscles in the body will be almost like paralyzed, but it might be having some twitches, it might be occur here and there in some area in the body, and the brain activity is markedly increased. And this, it will be now producing a good effect with the dreaming, good effect upon the brain function. And that's a rapid eye movement sleep. The patient, it will be, or the person, it will be almost awake up. And then he will be going. Now, by this way, now we are completing one cycles. Again, it will take about 90 minutes, and then start another cycles of sleep. Usually will take about like 3 or 4 cycles during the whole night. So let's start by talking about the sleep-wake switch. So we have a balance between the inhibition and the stimulation in the brain. The inhibition, it's through the action of the ventrolateral preoptic nucleus, which will be releasing the GABA as a major neurotransmitter. The GABAergic neuron, which it is releasing the GABA, and the GABA, as we already know, it is a major inhibitory neurotransmitter in the brain, and almost about like 40% of the synapse in the brain, they are dealing with GABA. And the melanin concentrating hormone, which it is a 19 amino acid peptide that will be active during sleep period. And the major inhibitory neurotransmitter in the brain, again, it is the gamma aminobutyric acid, the GABA. Now that will be in a balance with the stimulation that will be produced by the action of the locus coeruleus, which will be releasing the norepinephrine, and the dorsal raphe nucleus, which will be releasing the serotonin, beside the activity of the neurons that will be releasing the orexin. Now, in addition to that, we have some of the neurotransmitter, they are excitatory neurotransmitter, like acetylcholine and the histamine. And by this way, we have this type of a balance between the inhibition and the stimulation. And during the sleep, the inhibitory effect, it will be predominate. The classification of sedative hypnotic drugs. First group, we start with benzodiazepines. And as you can see, all the names of the benzodiazepines, they are ending with azolam or azepam. We have the second group, non-benzodiazepine receptor agonist. Here we have 3 medication: zolpidem, zaleplon, and isobuclone. A third group, the one melatonin receptor agonist. So we have 2 medication here, ramelteon and tasimelteon. Then a fourth group, the orexin receptor antagonist. I'm going to mention one drug, sulforexant. One drug by itself, buspirone, and another group, the antidepressants. Here I'm going to mention 3 medication: doxybin, trazodone, and mirtazapine. The antihistaminic agent, we have diphenhydramine and doxylamine. Now, these antihistaminic agents, they have many side effects and should not be used more than 3 to 5 days. Now, for all these sedative hypnotic drugs, if we are unable to treat the insomnia within 7 to 10 days, then that will be indicated that we have a real problem. Either we have medical illness or psychiatric illness and should be evaluated. And the long-term use of hypnotics is irrational and dangerous medical practice. It should not be used for a long period of time. So now let me remind you about the GABA receptors, that we have 2 types, A and B. We are concerned here about the type A. The type A receptors is composed of 5 subunits. They are forming a channel through the cell membrane. These 5 subunits, we have the alpha type, we have 2 of them. And here from the alpha subunits, we have 6 different subtypes. So here we have the alpha 1 subtypes. We have the beta subunits. Again, we have 2 of them. And we have 4 of these subtypes of the beta subunits. So here we are having the beta 2 subunits. And we have 1 unit of the gamma unit. And again, in the gamma, we have 3 subunits. So here we are having the gamma type 2. So the GABA has a 2 binding site on this GABA receptor between the interaction between the alpha 1 and the beta 2 in either direction. And whenever the GABA will be binding to these 2 binding site, that will be activating now these channels, which we call it a chloride channels, because it's going to open and let the chlor to get from outside to inside. And since the chlor is negatively charged, so we have hyperpolarization, which means that we are going to decrease now the firing of the neuron. So that's the reason GABA is an inhibitory neurotransmitter in the brain. Now, the benzodiazepines will be binding to the alpha subunits and gamma subunits, the interface between alpha and gamma subunits. And by binding on that binding site, it will be potentiating the activity of the GABA and increasing now the frequency of the opening of these chloride channels. The other group, that's the one we call it the non-benzodiazepine receptor agonist, the zolpidem and zeleblon and isobicolone. These will be binding again to the interface between the gamma subunits and the alpha 1 subunits only, will not be binding to another GABA receptor which contain a different alpha subunits, not the alpha 1. So only will be binding to those who having the alpha 1 subunits. And flumazenil, this is an antagonist for the benzodiazepine receptors, you can see again this will be binding again to the interface between the alpha and the gamma subunits on the GABA receptors. The benzodiazepines produce different types of effects. One of them, sedation, which is going to reduce the anxiety and also to produce anterograde amnesia. So the individual who is taking the benzodiazepine will not be able to build the new memories, which means that he is unable to remember the things that will be happening after taking the medication. Second, it will be producing a hypnotic effect. However, it need a little bit of explanation. So they will be decreasing the latency of sleep onset, which is a good one, but also they will be decreasing the duration of the stage 4 of the non-REM sleep, which again here in this stage 4 we know that the body repairing itself, so that will be here decreasing this duration. It will be bad actually. Also they will be decreasing the duration of the rapid eye movement sleep. Again here we know that the brain actually is improving its function through the dreaming. Again, that decreasing this one, it is a bad effect for the benzodiazepines. They are going to increase the duration of the stage 2 of the non-REM sleep. However, this stage 2 we know that it is a light sleep, so again there is no advantage of that. Then they are useful in anesthesia. In anesthesia, we have lorazepam for an example. We have diazepam, midazolam. All of these medication, it will be given as an IV before getting to the operation room. So by this way, they are going to reduce the anxiety, and also they are going to produce a little bit of muscle relaxation, and also will produce the anterograde amnesia, so the patient will not be able to remember the bad memories about the surgery. Also, they have anticonvulsant effect. So here we have, for an example, lorazepam, diazepam, that it might be given as an IV during the status epilepticus, for an example, or it might, for diazepam, it's also available as a rectal gel, can be given to the children if you are unable to find an IV line. And they have producing some skeletal muscle relaxation, which again, it is helpful in some injury for the spinal cord. However, they have different types of toxicity. Some of it is really a serious one, that the tolerance. So the tolerance, as you already know, that if we are giving the same dose of the medication, as you can see it here, then the drug effect start to be decreased. So to return back to the same effect, you need to increase the dose gradually and so on. And that's what we call it, the tolerance. And the tolerance then, whenever it will build, it will be ending to what we call it psychological dependence. So the patient now, he feels that all his system, it will be working in properly if he is unable to take the medication. And that's finally will be leading to a real physiological dependence. So now all the body system had been used to the drug. So otherwise, if he is not taking now the drugs, the body system function, it will be disturbed. And that will be leading finally to an addiction, which is really a serious problem. And some of the other toxicities, that it might be producing cardiovascular collapse or respiratory depression. So we have seen the structure for the GABA receptor type A, and how the GABA will be binding to these chloride channels and will be produce hyperpolarization inside the neuron. Now we are going to talk about the non-benzodiazepine receptor agonist. and those they call it the Z drug, because as you can see in their name there is a letter Z. So we have zolpidem, zaleplon, isopiclone. Now these medication, they will be binding to the interface between the gamma subunits type 2 and the alpha subunit, which it must be alpha 1 only. Now comparing the three medication, zolpidem, zaleplon, and isopiclone, we'll find that the first one will be decreasing the rapid eye movement sleep. The second one will be decreasing the latency of sleep onset. And the third one will be increasing the total sleeping time. The first one usually have a minimal effect upon the stage number 3 and 4, and the second one have little effect upon the total sleeping time, the non-rapid eye movement sleep, and also the rapid eye movement sleep. The third one usually will be increasing stage number 2, which it is a light sleep. Now, almost all of these medications, they don't have a rebound insomnia if you discontinue the drug, unless you are using it in a high dose. Also, these three medication usually will not be developing a tolerance until you have an extended use or you are using it in a high dose. Specifically for the third one is zopiclone, that it might not develop a tolerance even if you are using it up to 6 months. The first one, zolpidem, it's usually among the most frequently prescribed hypnotic drugs in the US, and the zaleplon, it's good for patients who are awakened early in the sleep cycle because have a shorter duration of action. Now, this medication, all of them, zolpidem, zaleplon, isopiclone, all of them, they are going to enhance the membrane hyperpolarization by augmenting the activity of GABA upon its receptors, the chloride channels. They have a rapid onset of activity. Usually in the management of sleep disorders, they have the similar efficacy to benzodiazepines. Now, these medication usually they don't change the sleep patterns. They are lacking any anticonvulsant activity. The same, they are lacking any muscle relaxation activity. And if you discontinue them suddenly, the patient usually will not be having a rebound rapid eye movement sleep. And also the withdrawal symptoms, usually it will be minimal and acceptable even if you stop the drug suddenly. Usually they have what we call it modest day after psychomotor depression. So in the next morning, they don't have a severe psychomotor depression, and they have just like a few amnestic effects. However, they have a serious problem. They might be producing what we call it a complex sleep behaviors. So some of the people who are using them, they might be getting out of their bed, they might be driving their cars, prepared and eat a food, had sex, might be making a phone calls, or they might be involved in other activities while they are not fully awake. And after they wake up in the morning, usually they are not able to remember any of these action which had been done during the night. Now, all of these medication, they consider category C in the pregnancy. So we already have described how the GABA receptors type A, how it will be working, and where the benzodiazepines and the Z drugs, where it's going to bind. Now we have the flumazenil. Flumazenil will be binding to the same almost binding site for the benzodiazepines and for the Z drugs at the interface between gamma and alpha subunits of the GABA receptors. Flumazenil is working as a competitive antagonist for the benzodiazepine, so it's going to block many action of the benzodiazepine and also the Z drugs. The clinical indication for flumazenil is in reversing the depressant effect of benzodiazepine overdose upon the CNS, and also to increase the rate of recovery that will be following the use of this medication. Flumazenil will be given an IV, and it has a short duration of action, so you need to repeat the dose until the patient will recover totally. However, he has different types of side effects that whenever you give it, it may lead to a confusion, dizziness, nausea, vomiting, agitation. But probably one of the serious toxicity that will be produced by administration of flumazenil, if the patient was a benzodiazepine dependent, that we are going to produce severe abstinence syndrome. So the patient will have blurred vision, might breach to the convulsive activity, increased sensitivity to noise, to light. He is unable to go to sleep and unable to maintain the sleep, and so on. But however, still now the major serious problem if we give flumazenil for those who having taken the benzodiazepines and the tricyclic antidepressant in this condition is going to produce severe seizures activity and cardiac arrhythmia.